Hello and welcome to TiCME, Time Critical Medical Education. My name's Nick Taylor and I'm an emergency physician based at the Canberra Hospital. Today's TiCME Plus tutorial is all about non-invasive ventilation and CPAP. Remember that if at any stage you need more time on any slide, you can pause the video or rewind. The goals for today's tutorial are to develop an action plan for the sick COPD patient and to learn how to use bi-level non-invasive ventilation. We're also going to have an action plan for a sick patient with acute pulmonary edema and learn how to use continuous positive airway pressure. Okay, so let's start with a case. You're in your emergency department when the ambulance turns up with a 78-year-old man with a past history of COPD. He's on 8 litres Hudson mask oxygen and has SATs of 79%. When you see a patient like this, probably the first 3 things that you need to answer are: what is this patient's normal saturations and are they on home oxygen? Are they a chronic CO2 retainer or not? And do they have an advanced healthcare directive which outlines what they would like to have happen in a situation of a severe exacerbation? Remember that in some patients, particularly those with chronic CO2 retention, the respiratory centre in the medulla is nowhere near as sensitive to changes in CO2 levels as it normally would be. In some of these patients, they are partially dependent on the hypoxic respiratory drive based around the chemoreceptors in the carotid artery. For more information about respiratory physiology and ventilation, please see the TiCME ventilation video. In a chronic CO2 retainer, you should usually only aim for SATs of 88 to 92%, or their usual saturations, and you need to use a Venturi mask or nasal prong oxygen to achieve this. When you are treating someone with an exacerbation of COPD, there's reasonable evidence that any sign of infection should be treated aggressively with antibiotics. So a sick patient with COPD will also benefit from bronchodilators and steroids. Remember that quite a significant proportion of COPD patients have a mix of asthma-like symptoms as well. Remember that you can run nebulizers on air and you can keep the nasal prong oxygen so you can titrate the FiO2. We'd prefer to use spacers whenever possible, as they confer a lower risk of droplet spread disease transmission. Remember to always sit your patient up, and if you have them available, using end-tidal CO2 nasal prongs for monitoring is a good plan. You can calibrate these with your first arterial blood gas so you can see what the alveolar arterial CO2 difference is, and then after that you can use your end-tidal CO2 prongs to track progress. Remember in a sick COPD patient to think about comorbidities. These patients have often been lifelong smokers and are therefore at risk for ischemic heart disease. So always do an ECG or a troponin to look for acute coronary syndrome. Be aware that there might be an underlying exacerbation of left ventricular failure, and in the patient who's suddenly become unwell, pneumothorax needs consideration. Remember, on a chest X-ray, it sometimes is difficult to tell the difference between a large subpulmonary bleb and a pneumothorax. Before you stick chest drains in, make sure that you've had a chance to review previous radiology. It's sometimes very difficult to tell the difference between a bleb and a pneumothorax, but commonly a pneumothorax will provide a crescenteric rim of air around the lung itself, whereas blebs will tend to be more localized. When you're assessing a patient who is sick with COPD, it's very important to do an early ABG or VBG to assess for the presence of respiratory acidosis and for the chronicity of the hypercapnia. So back to our patient. We've done an ABG as soon as he's arrived, and this is what we've found. So as you can see, there's a significant respiratory acidosis. However, if you were to look at the pH of 7.25, the experienced people might notice that you'd expect this to be lower for a CO2 of 76. In fact, the pH drops by about 0.05 to 0.1 for every 10 that the CO2 rises. So if this was completely uncompensated, we'd expect the pH to be around 7.1. Looking down at the bicarbonate, we see that it's elevated at 30. Now the bicarb rises for about 1 to 2 for every 10 the CO2 rises acutely, but will compensate by about 4 for every 10 CO2 chronically. It does take some time for renal bicarbonate compensation, so the fact that bicarb is 30 and the pH is higher than expected tells us that this patient has an acute on chronic respiratory acidosis. So we're maximally medically treating our patient. We've given them steroids and bronchodilators, controlled FiO2 oxygen, and antibiotics. We need to think very early about escalation plan in these patients, because if they're not improving immediately or they're failing your maximal medical therapy, we need to step up the treatment. To decide whether this is appropriate, we need to establish resuscitation status. In patients with COPD or CAL, I like to do a 4-step resuscitation or advanced care directive plan. It's very important that you have a logical approach to this, because patients will differ in what they deem to be appropriate. So I like to do, is the patient for all care, including intubation and invasive positive pressure ventilation? Are they for non-invasive ventilation but not for intubation? Are they for maximal medical therapy but not for non-invasive ventilation? Or in some circumstances, is the patient to receive palliative medical care only? So if you decided that it's appropriate to escalate medical care, you should start bi-level non-invasive ventilation early. The remainder of this talk will talk about bi-level in detail. Consider an arterial line early to allow better control and avoid multiple stabs to the artery, or you can continue using CO2 nasal prongs if you've calibrated the end tidal value with an arterial CO2. You should monitor the CO2 and PO2 at least hourly initially. And remember that if bronchospasm is a large component, and in some patients with coexisting asthma, this is a significant contributor, then consider increasing the medical therapy to include intravenous magnesium or salbutamol. So if everything goes very badly and the patient is failing no matter what you're doing, then you have to be very clear about the resuscitation status before proceeding to intubation. In general, most end-stage COPD patients probably should not be ventilated because the weaning process is almost impossible. In reality, you need to decide whether you think that there's a temporary reversible cause for their deterioration or whether this is the end of a long process of decline. It can be very difficult to intubate the hypoxic and unwell patient, so remember to get as much senior help as possible prior to intubating. When you put them on the ventilator, it's often that your troubles are just starting, but in general your ventilator strategy should be similar to that of asthma, in that you often need permissive hypercapnia, low respiratory rates, controlled tidal volumes, and low PEEP values. So let's now talk about non-invasive ventilation in detail. Okay, so let's start just by clearing up some of the nomenclature. In the literature, non-invasive ventilation is separated from CPAP. In general and clinical practice, we tend to call either CPAP or bi-level non-invasive ventilation. So CPAP stands for continuous positive airway pressure, and essentially just delivers a continuous single pressure. Non-invasive ventilation, which has different trade names, some of them you might recognise as BiPAP or the S&T mode or bi-level ventilation, involves delivering inspiratory pressure support and then settling back to the EPAP value. So EPAP is expiratory positive airway pressure and is essentially the same as PEEP. IPAP is the inspiratory positive airway pressure, and this is the inspiratory pressure support that the machine delivers to help with the patient's inspiration. So the indications for starting non-invasive ventilation are respiratory failure, either hypoxic or hypercapnic, not requiring or not appropriate for invasive positive pressure ventilation. In general, it makes sense to start NIV early rather than waiting for a deterioration. And certainly, most of the evidence around NIV suggests that if commenced early, intubation rates will fall. If you were going to design a machine for non-invasive ventilation, you would like it to be transportable, standalone, battery backup, and reliable. Ideally, you'd like to be able to deliver anything from room air up to 100% oxygen. You'd like it to have timed and demand modes, although in general, we generally only use the demand modes. You'd like it to have fantastic leak compensation. Ideally, you'd like it to be able to work with a range of face masks so they can be changed for patient comfort and face shapes. And in general, you'd like to be able to at least control EPAP, IPAP, and FiO2. The good news is that most of the modern non-invasive ventilators have all of these characteristics. There have been significant improvements in the technology over the last few years, and certainly patient tolerability and leak compensation have significantly improved. So bi-level non-invasive ventilation. The usual indication is hypercapnic respiratory failure. In fact, NIV is a level 1A recommendation for COPD exacerbation with a pH of less than 7.35 from hypercarbia. It's important to remember that the patient who comes in with a mild respiratory acidosis, i.e. 7.25 to 7.35, is more likely to do well. So instead of thinking of NIV as your fallback option for the very unwell patient, it's important to consider its use early in the patient who's mild to moderately unwell. The goal of NIV is to decrease work of breathing. Hopefully that will increase your tidal volume, and remember that minute volume is tidal volume times respiratory rate. So if the minute volume increases, the CO2 should reduce, thus fixing the respiratory acidosis. The work of breathing is theoretically helped by adding inspiratory pressure support. So as the patient takes a breath, the machine provides pressure support to augment tidal volumes and takes on the load away from the respiratory muscles. It's a common belief that bi-level ventilation is better tolerated than CPAP. However, a huge study on both of these modes in acute pulmonary edema seemed to indicate that CPAP was better tolerated. The reason for this appears to be that patients don't like the pressure. CPAP confers a lower mean airway pressure than bi-level does and is thus likely to be better tolerated. If you're starting someone on non-invasive bi-level ventilation, start by sitting them up. It's very important then to spend some time explaining what you're going to do and what the machine is going to feel like. Tolerability can improve significantly if you can decrease patient anxiety. Start low when you set your pressures. I recommend starting with an IPAP of 10 and an EPAP of 4. You can rapidly titrate these upwards, but if the patient doesn't tolerate your high numbers, then non-invasive ventilation will not be successful. We like to hold the mask on the patient's face until they feel comfortable. This allows you to take it away if anxiety is a big problem. It also allows you to work out what sort of pressure you need to apply to the mask to minimize leak. When you're starting off on bi-level, you need to slowly increase the IPAP to achieve the tidal volume that you're after. You do this by increasing the IPAP by 2 to 5 centimeters of water every 5 to 10 minutes. You do this until you see clinical improvement, or you reach your tidal volume goal, or if you reach the tolerability of the patient. Usually the maximum you can deliver through NIV is around 20 to 25 centimetres of water. Anything above this is not well tolerated and creates significant leak. You should slowly increase EPAP, but not more than an EPAP of around about 10, because you will encounter air or gas trapping over these values. For hypoxia, you may require more EPAP in the patient who has more significant amounts of consolidation or aspiration or pulmonary edema to those who have got very little consolidative process in the lungs. Remember that you should be running end-tidal CO2 prongs if possible, but if not, check your CO2 again in half an hour initially. So, how to progress? If the CO2 remains high, you might want to start by adjusting your FiO2 down to keep the SATs at 85 to 90%. Observe the patient for chest expansion, have a look at the tidal volumes, and if these appear to be inadequate, then you need to increase the inspiratory pressure support. If the CO2 baseline is rising, then you may be getting some rebreathing, and slowly incrementing EPAP may assist with this. Remember to check for significant leaks, and sometimes applying some Vaseline to facial hair may be all you need to do. If the CO2 is improving but the PO2 remains low, then you may want to try and get some recruitment of alveoli going. To do this, you may want to increase EPAP. Remember not to go above about 10 because you will encounter air trapping above this value. You should increase the FiO2 if absolutely necessary, but remember that in chronic CO2 retainers who have an element of hypoxic respiratory drive, you may encounter a reduction in minute volume after the FiO2 goes up. Remember also that increasing FiO2 will make the SATs look better, but won't augment or improve respiratory physiology. You need to remember that within 4 hours of starting NIV, you should have enough information to be able to make a decision about whether the patient is improving or whether escalation to intubation needs to be considered. Patient tolerability can be a problem with NIV, and if your patient is struggling, the first thing you need to do is reassure them and coach them. Sometimes a one-on-one period of nursing attention is all you need to get the patient through. If possible, you should try and reduce the mean airway pressures. If the SATs are doing very well, then reducing EPAP is the first step. If you have one available, a full face mask is often better tolerated than one of the tighter fitting masks. In general, I don't recommend using opioids or benzodiazepine for patient tolerance. Usually, the reason the patient is anxious is due to significant hypoxia or hypercapnia. Reducing respiratory drive further with sedative drugs will generally just make that problem worse. However, there are some situations. So either the patient who is so anxious they're unable to tolerate the mask and you think it's going to be settled with a small dose of benzo or opioid, or the patient who you've already decided intubation is not an option and they really aren't tolerating the mask at all, you may consider using small titrated doses as a last resort. So your patient's been doing well on non-invasive ventilation for the first 4 hours. How do you go about weaning your patient? Well, the available evidence is that patients who started with a respiratory acidosis and were put on bilevel ventilation have a high failure rate if they're weaned completely off within the first 24 hours. This failure rate in some studies was up to 50%. This doesn't mean that you can't wean any patient off, and particularly the patients who seem to improve very rapidly might be the ones who are significantly bronchodilator or steroid responsive. Sometimes these patients improve out of sight in the first 4 hours and can be safely weaned. But in general, it makes sense that weaning patients off fast isn't very successful because they haven't deteriorated to the point of needing bilevel in 4 to 6 hours. It's often been a week or two of a slowly building up infection with a slowly accumulating respiratory acidosis which has brought them to your emergency department. It doesn't make sense that that process is going to be reversed because of 4 hours of NIV in the emergency department. The evidence would suggest that patients on NIV should have at least 6 more hours in the first 24 hours after they've had the initial 4 hours of therapy. Weaning can be done by reducing the IPAP values or taking longer breaks off the machine, and is usually a combination of both. Some of the more elaborate non-invasive ventilators have modes to assist the weaning process. Okay, so we've talked about bi-level non-invasive ventilation. Let's now talk about continuous positive airway pressure. CPAP has got very strong evidence associated with its use in acute pulmonary edema, but unfortunately randomized controlled trial evidence for other indications is lacking. However, you can consider using CPAP for all of the other hypoxic respiratory diseases, such as pneumonia, pulmonary contusions, or aspiration. I particularly like using CPAP or bilevel as a bridge to intubation in a patient who comes in unwell with significant hypoxia. Instead of rushing to intubate a hypoxic and very unwell patient, place the patient on CPAP, dial up the PEEP in the FiO2, and then you can methodically and safely get together your drugs and your equipment and your staff for a planned intubation. Your pre-oxygenation will be far better after a period of PEEP than it would be that if you just laid the patient down and did a rapid sequence induction. CPAP might also be helpful in patients with hypercarbia, although, again, randomized trial evidence is lacking, and it's likely that bilevel will be better for this indication. So how do you start CPAP? Well, it's quite simple. All you need to do is start by selecting the EPAP you want to start with, and remember that EPAP is similar to PEEP. Usually, again, you should start low, around 5 to 8 centimeters of water, and increase by 2 to 5 every 10 minutes. Remember that what you're titrating to here is again work of breathing and symptoms, but also the oxygen saturations. Start by selecting a high FiO2 because you have hypoxic respiratory failure, and wean the FiO2 down as appropriate. Remember that the EPAP is helping by recruiting extra alveoli, by increasing the functional residual capacity, and by reducing work of breathing. In acute pulmonary edema, the EPAP also increases mean intrathoracic pressure, and this reduces venous return to the heart. So, if the patient remains hypoxic on CPAP, then you should increase the EPAP and then the FiO2. Remember to also increase your medical therapy. So for example, in acute pulmonary edema, you may want to also increase the GTN infusion. If the patient is becoming progressively more hypercapnic on CPAP, I usually change them to bilevel mode and add in some IPAP. If you're weaning the patient off CPAP, I usually decrease the FiO2 first and then wean off the PEEP. So how do we treat the sick patient with acute pulmonary edema? Remember, for more information, you can watch the TiCME tutorial on heart failure, which goes through this in great detail. But in general, you should start by sitting the patient up. Again, this will help to redistribute fluid in their lungs. Put the patient on high flow oxygen, put them on a cardiac monitor, and call in your X-ray person. Obtain IV access, and remember to get a 12-lead ECG as soon as possible to make sure there isn't an acute coronary ischemic process going on. Any patient who isn't hypotensive will benefit from GTN for preload and afterload reduction. So you can give 300 to 600 micrograms under the tongue. Start the patient as soon as possible on CPAP. Remember to start with a PEEP of 5 to 10, going up to a maximum of 15 centimeters of water. If the patient is clearly volume overloaded, then giving some furosemide IV is appropriate. However, it does not form the mainstay of treatment for acute pulmonary edema. We do not recommend giving morphine in acute pulmonary edema. There is now a multitude of studies showing increased mortality when morphine is used in these patients. The reason isn't too difficult to work out. Remember that your patient has got significant hypoxia and is struggling to breathe. Morphine, as you know, is a respiratory depressant. It's not a very good vasodilator, certainly not as good as GTN is. So, in essence, what we're giving is an anxious patient who's hypoxic, a respiratory depressant, instead of a vasodilator. You can stick on a GTN patch if you have one available, or start a GTN infusion. Remember, with GTN infusions, the half-life's very fast, so you can start low, titrate up rapidly, and if the patient's blood pressure falls, just reduce the infusion. Remember to continue to treat the patient for acute coronary syndrome if this is present as well. Okay, so we've looked at NIV and CPAP. Let's do some practical scenarios to reinforce what we've learned. Start with a 64-year-old man with end-stage COPD. His SATs are 75% on 6 litres of oxygen. You do a blood gas and you see that there is a significant respiratory acidosis. The bicarb's 31, so you think this patient probably has chronic hypercapnia with an acute exacerbation. What do you do? So remember our action plan for a sick patient with COPD. We need to institute immediately maximal medical therapy, which includes bronchodilators, steroids and antibiotics. We need to give them controlled FiO2 oxygen, aiming for their normal SATs, and we need to immediately establish whether this patient has an advanced healthcare directive or not. In the patient who isn't immediately responding to therapy or is deteriorating, we need to institute non-invasive ventilation early, starting at the parameters of around 10 on 4 and titrating IPAP upwards to augment tidal volume and reduce work of breathing. You can give yourself 15 to 30 minutes for the patient to settle in to allow time to accumulate more information, such as whether the patient is for invasive ventilation intubation if they continue to deteriorate. Okay, so what about a 75-year-old female who's on CPAP for acute pulmonary edema? You've got her on settings of PEEP of 8 and an FiO2 of 50%. At 1 hour, you do an ABG. The CO2 is 35, the pH is 7.28, and the PO2 is 56. What do you do? Okay, so in this patient with a normal CO2 and the pH is slightly low, there's clearly a metabolic acidosis. We don't really need to fix the CO2 at this point because it will be helping to compensate the metabolic acidosis, and the PO2 of 56 shows us that the patient is still hypoxic. So, if the problem is acute pulmonary edema, we need to increase the medical management for this, and this might include increasing our GTN infusion if the patient's blood pressure will tolerate it. But from a CPAP perspective, we only have PEEP of 8. So in this situation, I would increase the PEEP from 8 to 10 and watch our SATs to see if they improve. If they don't improve in the next 5 to 10 minutes, I would turn the PEEP up by another 2 to 3 and watch for improvement again. Remember, if the patient isn't improving as you would expect, to look for complications. So at this stage, I would also repeat an ECG and can consider repeating the chest X-ray. Okay, a slightly more challenging one now. A 74-year-old patient with a history of COPD comes in with pneumonia. You do an ABG when they arrive, and you notice that the CO2 is 42, the PO2 is 48, and the bicarb's 23. You also notice that they're on quite a significant amount of oxygen to achieve SATs of only 91%. You think this patient needs to start NIV? So how would you start it? So although this patient has a history of COPD, the gas indicates that they're unlikely to be a chronic CO2 retainer with a low bicarb and a normal CO2 value. The most significant problem for this patient at the moment is their pneumonia causing hypoxic respiratory failure. So you have two choices, whether you start this patient on CPAP to fix the hypoxia, or whether you start the patient on bi-level, but with an emphasis on the EPAP value. I think in this setting, I would start the patient on bi-level, but I would remember that my goal is to fix the hypoxia, and I would be augmenting the PEEP to try and achieve better SATs. Okay, so you started off on relatively low values of an EPAP of 6 and an IPAP of 10. You're on an FiO2 of 0.45 after 30 minutes, and you do another ABG. That comes back with a CO2 now of 58 and a PO2 of 65. What would you adjust? Alright, so the first thing is that the PO2 has significantly improved with only the addition of 6 of EPAP. We've managed to almost halve our FiO2 as well. Now we'd still probably like our PO2 to be slightly better, so I think we've got some room to move here to increase our EPAP. So I would move the EPAP from 6 to 8 and reassess my SATs. But the other thing we've noticed is the CO2 has climbed from 58 from 42. Now I think this is probably because the patient has the background history of COPD. So in this instance, you need to increase the IPAP, so I'd increase the IPAP from 10 to 12, and use my end-tidal CO2 prongs or repeat gas in 30 minutes to assess progress. If tidal volumes are clearly low, or the patient is struggling, then stay by the bedside and increase the IPAP in increments of 2 to 5 every 10 minutes until you achieve your goal. Okay, so the final case, we've got a 72-year-old female with chronic obstructive pulmonary disease who's been on non-invasive ventilation for 4 hours. They're on the bi-level mode, IPAP is 15 and the EPAP is 6, and they're on a controlled FiO2 of only 0.28. You do another gas and the pH comes back at 7.5, the CO2 is 46 and the bicarbonate is 40. What's happened here? And what should you do about it? So the first thing to say is that your patient's done really well. They seem to have dramatically improved. From what would have been a respiratory acidosis, they now have a metabolic alkalosis. But why has this happened? Well, if you have a look at our CO2, we've pushed it back to nearly into the normal range. The bicarbonate is very high. This would indicate the patient would normally have chronic hypercapnia. So what we've essentially done here is overventilated our patient. We've made their CO2 normal, but this patient would be used to having a CO2 maybe in the 50s or 60s normally. So what's happened is the bicarb, which has been retained by the kidneys to compensate all that extra CO2, is now free in the bloodstream to cause a metabolic alkalosis. So your response to this is to help the CO2 drift back towards its normal range, and the way to do that is to reduce IPAP. Thank you very much for watching this TiCME tutorial on non-invasive ventilation and CPAP. I look forward to seeing you next time on TiCME.